Hello, good morning, everybody. Welcome. How are we doing today? Happy Tuesday, I guess it is. All right. Well, welcome back for another exciting week of something. All right. So we are going to begin today with just a couple quick announcements, and then we are going to jump into some of our allergy and immunological diseases. So just as a reminder, guys, because we did not have class yesterday, I'm going to start with just the beginning of the lecture, just like I normally would. So you're basically getting the day one information. Wouldn't make a whole lot of sense to start with the day two information. So your second piece will come in a recording. That should I should get that out to you tomorrow. I didn't realize that I don't actually have another one of these classes this week due to immersion, so I have to create a recording. So that's going to just take me a day or so to get pulled together. Um, so watch for that tomorrow. Additionally, guys, I just want to let you know I did add a few slides here this morning. I've always thought about this and I just decided to do it this morning for some reason because, procrastination is the key to everything, right? So I threw some extra slides in there. I will make sure that you guys get those slides. I just haven't had a chance to send them out to you yet, but I think they do a really good job clarifying some of the key points that we have out there for you. So just know that's as we go through this, some of the things that you see are not going to be in your slideshow, but you will get them. Um, so we have that. Um, as far as assignments go, we are opening up the ATI for this week, the practice assessment. So jump in there, make sure you get that completed this week. Remember, you're just taking the test this week. There's no remediation due. There's nothing you have to turn in at this time. It is all just you taking it. So if you don't have access to that, if you could please at least check before we get to the weekend to make sure you have access to it. It'll show up on your screen, and if it's not there, please reach out to me before the weekend so that you guys can get that completed, okay? Um, so that's our big thing coming this week. Next week is your first exam in this course. So kind of have your heads up for that. As you guys know, that it's going to be our usual timing on that Tuesday, Wednesday, Thursday, 6 a.m. to 10 p.m. Um, Another good reason to make sure that you have access to all the ATI stuff just because you don't want to get to test day and not have the right stuff there for you. So we'll get that exam done next week. So make sure you guys are attending the sessions that we have for you as far as the practice question sessions. I'm going to get some practice questions out to you guys this week that hopefully you can work through, give you some insight onto some of the other topics or just kind of put it into question form, if you will. Um, so that's kind of the upcoming events. So any questions that you guys have? All right, you guys are looking great. All right, so let's get transferred over here to the world of PowerPoint. So give me one second. I got to get everything shared here. There we go. All right, guys. So this week we are going to be primarily focusing on our allergic reactions, our inflammatory responses, and our rheumatic disorders. So you guys are probably familiar with rheumatic disorders just a little bit. We will talk about those as we continue to go through today's lecture. So let's see here. So Sierra, the assessment should be finished by Sunday night. Okay. Your remediation, I believe, is due in module five. Okay. So I just got a question there in the background, guys, about when is that assessment due? And I'm for the ATI. So that will be due on Sunday, just like normal. Okay. So as far as what we're going to be doing today, we're going to talk about allergic disorders, and then we're going to talk about some of those rheumatic disorders that we might come across with our patients. One of the things that I think is a more challenging concept in the world of nursing is our allergic disorders. And not from the standpoint of like, hey, here's an allergic disorder. I think I could ask all of you if somebody's having an allergic reaction to something right now, what are you going to do for them? And you would come up with answers anaphylaxis, heart rate, airway, breathing, circulation, all of those things. But As you know, in the world of the human body, things are never that easy. So, this is kind of the first intro slide. Okay, this is a good overview for you of our different types of hypersensitivity reactions. Now, I this is where I started to add some of those slides into there, guys. So this all really starts with kind of the idea of what is our immune response supposed to do, and how do we break that down then into kind of that hypersensitivity response. So our normal immune response, as you can see, is really this pathogen or this virus, bacteria gets into the body. It activates these antibodies within the body, and we are then able to neutralize the response in the immune system. Unfortunately, sometimes it doesn't quite work that way. Sometimes what happens is the body over responds to something that's there. And we've listed a couple of things on here: pollen, dust. Those are very common allergens that people have to deal with. And for some people, there's an excessive activation of that immune system. So think about if you've ever had allergies before, even if it's just seasonal allergies. Okay, you go outside, it's springtime, you have an allergy to grass, your eyes get itchy, your nose gets stuffy. All of those things start to happen to us when we are having those allergy responses, or those hypersensitivity responses to the different allergens that are out there, which makes one of the more important concepts when we talk about the idea of hypersensitivity to really think about the idea of exposure. Okay, so we talk a lot about the idea of, hey, if you're allergic to something, don't eat it, don't have it, don't try to stay away from it. If you have a pet that you're allergic to, do you keep that pet and suffer, or do you get rid of the pet? So exposure to those allergens is a really kind of key thing that we want to always educate our patients about. Now, from a cellular standpoint, what does this kind of look like? And guys, I'm not going to test you on this specifically, okay? I want you guys to understand this concept, which is why these slides are in here, and which is where I thought the weaknesses were in the previous presentation that you had. You didn't have access to this. So, what are our major players? So, we have our mast cells and our basophils. These are the things that are going to start off with that allergic response. And they are located in our skin, in our respiratory system, in our intestinal mucosa, and they have a very high sensitivity or high affinity for IgE receptors. Now, IgE receptors simply are things that allow the allergen to be received on the body. It recognizes it, it says, hey, this is a problem for us. Whether it's a peanut, a bee sting, whatever it might be, it helps us recognize that. And in response to that, we are going to utilize some of our normal processes, are what we call mediators here. Okay. And the first one that we want to talk about here is something called histamine. Okay. So what do we tell you to take if you're having an allergic response to something? We tell you to take a Benadryl, right? And why do we take Benadryl? Because it's an antihistamine. Histamine actually will cause the vasodilation. It will cause the bronchospasms. It will cause the itching. So if I get stung by a bee and I'm allergic to bees, my body's response is to release this histamine. It's a protective mechanism that's working out of control. Okay, and it causes these allergic responses, which is why we use the Benadryl to reverse this. Okay, as this continues on, we begin to release a significant amount of other chemical mediators. So our leukotrienes, okay, so after the histamine starts working, after all of that happens, we move into the second layer of response. And this is where we're going to see leukotrienes, we're going to see bradykinin, we're going to see prostaglandins. These are all chemical mediators that basically create a enhanced allergic response to this. Again, the body is recognizing this as a foreign invader. It is doing the things that it is supposed to do in order to manage that issue. However, it can get out of control. And that's really what we're talking about throughout this entire lecture, is that idea that the allergic response can get wildly out of control due to overexposure and lack of ability of our own body to not be oversensitized to that response. So, so as you continue to expose yourself to that allergen, you're going to continue to see those symptoms of deterioration occur. Now, this comes in multiple different forms, okay? And you don't certainly have to need to know the Gell-Coombs classification name, okay? But there are very specific types of hypersensitivity reactions that we come across quite frequently, okay? Now, the one that we spend the most time talking about right now in this section of the class is our type 1 hypersensitivity reactions. Now, our type 1 hypersensitivity reactions are our anaphylactic reactions. They happen very quickly and they are mediated by IgE. This is something you're going to want to know. Just you don't necessarily need to dig deep into these, but if you can't remember this from some of your pathophysiology or nat and phys, it might be a good idea to just look on Google for a quick table on the different immune mediators, the IgE, the IgG, the IgM, those sorts of things. That's going to be helpful for you. Just kind of make sure you understand this. Now, because this works so quickly, and this is the thing that causes anaphylaxis, this is something that we are always watching for in the world of healthcare, particularly because we're giving a lot of medications that could be new to patients. Many patients have issues with things like antibiotics. So that comes up. Blood transfusions, that's another major issue that we come across um, with our patients. Certainly doesn't always fit perfectly into the anaphylactic reactions, but there is an anaphylactic component to it. But this also includes like our food allergies, etc. So this is probably the most common type that you're going to deal with. Now, our second type is going to be our cytotoxic type of oh gosh, what are these things? Hypersensitivity reaction. I'm sorry. This occurs from hours to days, so it's not like an immediate response. This is the person who has maybe again like a blood transfusion could apply here. Okay, so blood transfusion infuses, patient is doing okay-ish, but you can kind of tell something's not quite right. And then later in the day, they start to feel really crummy. They get really flushed in their face. They start feeling like it's maybe a little more difficult to breathe, so on and so forth. Um, so always kind of watching for that type 2 cytotoxic reaction. Again, I would kind of associate that formally with our blood transfusions, but also things like myasthenia gravis or Goodpasture syndrome are all syndromes that could be included there. Third type, immune complex. Okay, this is one that we see fairly often with our autoimmune diseases. Okay, hours to days, and this is basically going to cause some sort of antibody to form on a vessel or a joint, which causes inflammation. And kind of the examples that make this make sense are things like lupus and rheumatoid arthritis. Those are two of the top ones that we're going to talk about here as type 3 immuno hypersensitivity reactions. And then we have our type 4, which is going to be probably the easiest way to know this one is this is going to be your TB skin test. Okay, so we give you that test, we wait for 24 to 72 hours. We check that test again, and we're looking for that sensitivity that occurs there. This is going to release some cytokines into that tissue, which is going to damage that tissue, which is how we know it's there. And this also is caused by things like contact dermatitis, such as poison ivy, or possibly even a graft rejection. So I know many of you have probably had a TB test before. You may not know how they exactly work. Well, the way they work is we inject you under the skin with that small little antigen, and when we read that test, we actually rub our hand over the top of that injection site, and we're looking for something called an induration. Okay, and this is going to be like a hard patch of tissue underneath that area. The larger that area, the greater damage you have, the greater exposure you have to tuberculosis. Okay, so so those are the four types of sensitivity reactions that we have. Now, typically speaking, with our type 1s, you're going to have this element of sensitization that occurs. Okay. Sensitization is usually the reason that the first time that you're exposed to something, nothing bad happens to you. Okay. But it's that re-exposure that causes problems. Okay. It starts to bind to those antibodies. Okay. And makes a bridge between them, which causes a release of that histamine, which again causes us to have that anaphylaxis, that airway situation in the very systemic nature. But commonly, this is just going to lead to things like hives, hay fever, or rhinitis. Okay, the typical signs and symptoms that you would see, the itchy eyes, so on and so forth. So that's what we're typically seeing with that type 1 reaction. To further explore type 2 and 3, kind of have similar responses here. Okay, so we have the antibodies, the allergen comes in, and it's going to begin to recognize our normal cells as foreign. Okay, so for whatever reason, as the antigen begins to sit on the cellular surface, it begins to break down the actual cell itself. So you can see how this would be a very significant reaction, particularly if this was bloodstream related. Okay, and they mentioned very specifically here hemolytic anemia. Okay, hemolytic anemia is certainly an allergy or an allergic response. However, it is considered to be a type 2 response. And again, this is because when I get that kind of wrong blood, okay, and that's typically how this occurs, what happens is the body begins to recognize all blood as bad and starts to break down those cells, leading to hemolytic anemia. Anemic because I have broken down all of my red blood cells. Um, in the world of our type 3s, the antibodies are going to basically form insoluble complexes that are going to be in the joints, vessels, and kidneys. This is why when we talk about those autoimmune disorders, one of the common themes that we talk about is, hey, you have rheumatoid arthritis, which is in your joints primarily. However, it is a systemic disorder. And one of the areas that's primarily impacted outside of the joints is going to be liver. Okay. Or I'm sorry, kidneys, because those antigens build up inside of the kidneys. All right. And finally, with our delayed cell-mediated hypersensitivity reactions, these are going to basically have that exposure. And this oftentimes, again, leads to just contact dermatitis. However, okay, this is the reaction that causes Stevens-Johnson syndrome or toxic epidermal necrolysis, which we're going to get into in a little bit. Okay, so this is something we can commonly see in healthcare because a lot of times Stevens-Johnson syndrome comes from the delivery of medications to the client. So to help make this make even more sense, because I am a big believer that to understand these concepts, you have to understand the basics behind it. I'm going to show you a video. Okay, so we're going to do 8 minutes here on the different types of hypersensitivity reactions to hopefully help this make a little bit more sense to you guys. I am going to post this right now. Oops, nope, I'm not. I will post the link to this in just a second. Give me a second here. I copied something else, so it didn't like me trying to copy that into the chat box. But oops, sorry, Haley, I sent that right to just Haley. Let me do that again. There we go. All right. So here we go, guys. Let's watch our video here on hypersensitivity reactions. Let me share that. And here
reactions. We have type 1, type 2, type 3, and guess what? Type 4 hypersensitivity. And this classification is based on
guy's
what,
weird.
medicosis? It's based on the time mainly. Type 1 is the fastest, type 4 is the most delayed. With that said, now let's get started. Hypersensitivity, type 1, type 2, type 3, type 4. Type 1, immediate, but type 4 is delayed. Okay, about type 2? Cytotoxic. Look at this. Type 2 is Cy2 toxic. And type 3, you have free antibodies. What do you mean by free? I mean the antibodies are floating in the plasma. They are floating in your blood. They are not bound to cells. They are not Cy2 like type 1. Also, you can describe type 3 by 3 words: serum immune complexes. Hypersensitivity. Which one's the fastest? Type 1. Which one's the slowest? Type 4. Can you describe type 1 in few words? Sure. Immediate.
Right now, a
Sorry.
child is being diagnosed with cancer.
We cannot.
Anaphylactic. IgE. Mast cells. They rupture. Pew! They degranulate. Pew! Releasing histamine. And histamine can give you the symptoms of an anaphylactic shock. How about type 2? Cytotoxic. What do you mean? I mean, I have antibodies, okay? These antibodies are bound to antigens, okay? And this happens on the surface of the cell. The cell is the cyto. That's why type 2 is cytotoxic. Okay, how about type 3? 3 is free. You have antigens and antibody complexes. Same as 2? Yeah, but with one difference. The big difference is this happens in the blood. And after this, since they are hanging around in the blood, the antigen-antibody complex can end up being deposited in the blood, causing vasculitis, in your joints, causing arthritis, in your kidney, causing nephritis, etc., etc., etc. In type 1, type 2, type 3, we talked about antibodies like IgE, like the antibody that is cytotoxic, like the antibody that's freely floating in the blood. But type 4 has nothing to do with antibodies. Type 4 has nothing to do with the humoral immune system. Type 4 is about T lymphocytes, cell-mediated immunity. No antibodies? Heck no. The T lymphocytes are super sophisticated. They communicate with each other via cytokines, which include the interleukins, which is the internet of the leukocytes. This is also the story of making a granuloma, and this takes time. Here's a quick overview of the 4 types of hypersensitivity. Type 1, immediate, okay, within minutes, alright? Humoral immunity, which means I'll say antibodies, yes, such as IgE. Immediate, humoral, preformed antibodies. Remember, IgE is ew. What do you mean by ew? Allergy, anaphylaxis, atopy, asthma, eosinophil, ew, bee sting, ew. How about type 2? Type 2 is cytotoxic. Okay. We have an antigen-antibody complex. We're on the surface of the cell. And these antibodies could inhibit the target most of the time, or they could stimulate the target in one case only. That's why some crazy textbooks define this specific type as type 5 hypersensitivity. But this is a very bizarre classification that only lasted for 5 minutes, and then they went back to classifying hypersensitivity as 4 types. Can they inhibit the target? Sure, they can cause inflammation and cell dysfunction. Inflammation is seen in anti-glomerular basement membrane antibody disease, also known as Goodpasture syndrome, rheumatic fever, hyperacute transplant rejection. This is how your body rejects organs. Or they can cause cell dysfunction such as myasthenia gravis and pemphigus vulgaris. My muscles are in trouble, my skin is toast. They stimulate the target organ only in one case, which is the case of Graves' disease. I have antibodies against the receptor. Okay, what kind of receptor? This is the receptor waiting for the TSH. So it's called the TSH receptor. Okay, but these antibodies will come and stimulate the target. Have you ever heard of antibodies that stimulate the target? No, antibodies are weapons of destruction. Now this is an exception. These are antibodies that stimulate the target, leading to what? Well, it's as if TSH is binding to its receptor. Oh, so a similar effect? Yeah. What does TSH do? It tells the thyroid gland to secrete tons of thyroid hormone. So Graves' disease, in a sense, is a type 2 hypersensitivity reaction. Okay? How about type 3? Type 3 is also antigen-antibody complex in a different location, floating freely in the plasma. Okay? This is the cause of serum sickness, which is a diffuse and acute reaction, or the Arthus reaction. It's not diffuse, it's very localized in one spot on your skin, and it's not that acute. Arthus is subacute. Serum sickness is generalized, Arthus is localized. Serum sickness is acute, Arthus is subacute and subcutaneous. Love it. Subacute, subcutaneous. Type 3 is also the tragic story of the nasty immune-mediated vasculitis, when these antigen antibody get deposited into the wall of the vessel. This is vasculitis. They can also get stuck into your kidney. This is called immune complex mediated nephritis. or into your joints. Immune complex arthritis. This is what happens in lupus, this is what happens in rheumatoid arthritis and gazillion other diseases. How about type 4? Type 4 is the most delayed, 3 days or about 72 hours or slightly less, slightly more. This is cell mediated. I'm not gonna send antibodies to destroy. No, I, myself, I'm gonna go and kill that bacteria face to face. I'm gonna have a strong word with this tuberculosis face to face, cell to cell mediated or cellular immunity. If I can kill the stupid invader, I will destroy it. How will you destroy it? Well, we are T lymphocytes. We have T cytotoxic cells. We kill. Okay. But if I can't kill it, well, at least I can surround it in a granuloma. This granuloma can have caseous necrosis, such as the caseating granuloma of tuberculosis, histoplasmosis, blastomycosis, coccidioidomycosis. Or it could be non-caseating. Basically, any other granuloma is going to be non-caseating. A famous example is sarcoidosis. How to make a granuloma is a story that we'll talk about soon, but basically, CD4 T lymphocytes will secrete interferon gamma, which will stimulate the macrophages to make the granuloma. Brace yourself for the next video because we will discuss type 1 hypersensitivity reaction, the story of the asthma, the atopy,
All
the
right,
bee
guys,
sting,
that's enough
first
of that.
exposure, second exposure.
All right, so hopefully you get the point. All right, so lots of different types of hypersensitivity reactions that you can see with your patients. Now, the question is always not what is the disease, right? This is just the precursor. It's what do I do about it? So here's a good way to think about it. Act fast protocol. Okay, so first thing you want to do is something I mentioned already in this class is remove the trigger. Okay, so stop the IV, get the stinger out, and give that patient high flow oxygen. Okay, if the patient happens to be in the hospital, you can call a rapid response, start CPR if cardiac arrest occurs for that patient, and then put the patient in not Trendelenburg, but because we don't really use Trendelenburg much anymore, we want to use modified Trendelenburg. So if you're unfamiliar with modified Trendelenburg, that's where the head of the bed remains flat, but the legs get elevated. This returns blood without causing any sort of airway compromise for the patient. Okay. Then we move into our first line of drug administration here, which is going to be epinephrine, which we're going to talk about in a moment here. Then we're going to give our adjunct medications. This is going to be the use of those antihistamines. This is going to be IV fluids. This is going to be albuterol. And the last thing that I would add to this is the use of steroids. Okay. Um, we want to watch for a biphasic reaction, meaning that the reaction kind of comes back. This is why we actually use steroids because say you get stung by a bee, okay, and you're allergic to bees. We give you an EpiPen, we give you antihistamines, so on and so forth. You're feeling pretty great after you get all those meds. But after about 4 hours, that antihistamine is going to be gone. That epinephrine is long gone because that's got a very short half-life. So all of a sudden, you start to feel crummy again. That's because your body hasn't truly cleared that allergen out of the body quite yet. So the allergic response will return. So that's why you need to continue to monitor these patients. And finally, teaching about that EpiPen training and how to avoid some of these triggers. Okay. Now, to call into account here a couple of different definitions, etc., and disorders that we're worried about. Just want to cover some of that here. Okay, so end of the day, allergies, inappropriate response by the immune system. The allergen is the thing that is causing the allergic response, and then atopy, the last term that you see on here, is going to be our allergic reactions that are characterized by the different disorders that we see. So like allergic rhinitis, asthma, dermatitis. So basically think of it like the symptoms. Okay. Now, generally speaking, with our allergic reactions, there's a combination of things that we're always looking for. Now, anytime we deal with allergic reactions, we want to focus on ABCs. Okay. Airway, breathing, circulation has to be the number one priority here. However, that doesn't mean that there are not other symptoms that we can deal with. And oftentimes, those are the more common symptoms that we're going to see. For example, patients can develop things like asthma, allergic rhinitis, eczema, okay, itchy skin. Okay, so those are all common things that you would expect to see from somebody who's having an allergic response. And I know for me, I don't know about you guys, but when I think about different things, like when I say allergic response, the first thing that always comes to my mind is like the worst. Okay. Try not to always think about things from the worst. Okay. Think about it just from like I have to treat just a normal person, that doesn't have these severe signs and symptoms. So, what are things that I would be kind of talking with my patients about? Well, with eczema, which is going to be that skin reaction, okay, topical steroids, avoiding that offending thing. Oftentimes it's from like a soap or something of that nature that can cause it. Allergic rhinitis, using some of those inhaled steroids and antihistamine sprays. These are all common interventions that you're going to see in treatment of patients with allergic reactions. Just really focusing on the removal of that antigen or suppressing the immune response through the use of steroids to help us improve the way that our body manages some of those additional allergens that are present there. Okay. Now, what are some things, okay, that you are going to do as a nurse to understand a patient's allergy status? So I'm going to give you guys a chance to throw some things in the chat box there, things that are uh, things that you would assess. Okay, so I'm going to just ask if they have any allergies. Perfect. What else? Okay, so verification. Ask what reactions. Okay, good. Type of reaction, very good. Did they use any new products recently? Good. How sensitive the allergy is? That's good. Okay, okay. How do they handle that? Good. And I'm thinking, Viviana, you're kind of going with, the idea of how do you typically treat this? Okay. What do you do when you have it? Have you had it before? Are you taking any meds for it? These are all good things, guys. Okay. So starting to explore this idea with our patients is the most helpful thing to do. Always make sure that when you are obtaining any of this information, that you are documenting this somewhere. That's an important step when it comes to allergies, to ensure that the next person knows so that this doesn't continue to be a problem for the patient. Now, this is great, like in interdepartmental or intersystem type of things. Like if I go to one doctor in my system, the other doctors in that system will know. But say I travel to, Florida and I have an allergic reaction, they probably don't have that stuff on file. So it is important for us as nurses to document that and validate it if we can in some sort of way. All right. Now, the next thing that I do want to talk about, because it is really the biggest thing that we're concerned about, is anaphylaxis. Okay. So, yeah, itchy skin is bad. Allergic rhinitis sucks. Itchy eyes is horrible. Having an asthmatic response, not a lot of fun. But most of those things are more of a nuisance than they are killers. Okay. The killer is that anaphylaxis, and it is again caused by that excessive rapid release of histamine that we see with that type 1 reaction. It will have a variability in its symptoms from mild, moderate to severe, and they oftentimes will come on quickly. They can progress over time. They will progress over time, but they will almost always start very, very quickly. Now, as nurses, our most common pharmacological cause of this is penicillin, which is why I brought up medications earlier, because this is something that we do need to watch for when we're taking care of our patients at the bedside. You oftentimes patients come to the hospital with some sort of infection, and we're going to be delivering a lot of antibiotics, and some of those patients might be, the term we use there is naive. Their body is naive to that antibiotic. And remember, guys, that sometimes you have to wait until the second dose before you start to see that allergic response occurring. The first time it happens, the body just has no idea what's going on. The second time you're exposed to it, now you have all these antibodies that release that histamine, which is the problem. Okay, this is why sometimes, like, this is a good example. Like my youngest son, he used to get tons of ear infections. First time we had him treated for his ear infection, they put him on some penicillin derivative. And he took it. First couple doses were great. By day three, kid was covered in hives. Okay. Allergic response. Not to the first dose. 3 days later, problem. So you go in, you get a new antibiotic. All right. So that's kind of how that happens. Now, the causes are multifaceted. All right. Common things we see: food, medications, insect stings, and latex. And with anaphylaxis, our biggest concerns are bronchoconstriction, angioedema, urticaria, and hypotension. So you can see this picture of this young little feller here. He definitely has the signs and symptoms of anaphylaxis that I would be very, very concerned about. First thing I look at when I see this child is what? What do you guys look at when you see this and say, uh-oh? Yeah, you're looking at that airway because those lips are huge, right? Okay, so I'm really concerned because what's happening externally is also happening internally. Okay, so my throat is beginning to swell up, okay, meaning that I'm not going to be able to breathe. So that's one of the common things we're looking at. You can also see some urticaria, which is just those hives that are forming on the tissues here. Difficult to assess in this situation whether they're having any sort of wheezing or anything like that going on. Certainly doesn't look hypotensive, seems to be awake, alert with it. This would definitely be a kid where I'd be thinking about, we probably need to consider the use of some epinephrine here. And then the secondary step here is, kind of, I've talked about this idea in the past, but really that idea of be prepared. Okay. You don't know when this kid is going to all of a sudden fail on you. You may need that extra respiratory support. So get your oxygen tubing ready. Make sure that you have intubation equipment available and possibly even tracheostomy equipment. If you have a giant, and most facilities do have this, like an airway kit or box or something like that, that contains all the things that you might need to rapidly intubate and protect an airway for a patient. I'd get my patient some fluids, okay, because there's a chance that they're going to be hypotensive as well. We don't know from this image, but it is something we could be concerned about. Um, so again, I think the message here is be prepared for any of those challenges. Now, our job is going to be assessing that client. Again, A, B, C's here, guys, and focusing on the delivery of those priority medications. Typically, if it is severe, the drug of choice is going to be epinephrine. Okay. And the epinephrine we're going to typically give the patients is going to be intramuscularly. This should be given anytime we have any of those signs and symptoms of swelling, wheezing, and hypotension. Again, give that patient oxygen and prepare to give some of those adjunct therapies that we've talked about. So, again, if this is a histamine response, I want to give antihistamines. I'm going to give steroids because they are longer acting. I'm going to open that airway using bronchodilators such as albuterol. Okay, oftentimes it's not uncommon to place your patients on a like nebulized albuterol when they come into like the emergency department, and then those IV fluids for the patient. Now, another piece of this puzzle, and your image looks a little bit different. I think this one's better, but how do I give these things? Now, one of the things that's important from a nursing standpoint is really focusing on how do I educate a person to give their epinephrine to themselves or a friend or family member to do that. So first thing we want to do is look for the emergency situation: swelling, vomiting, fainting, tubie. I don't know what that is. I don't know if that's even a word. Um, hives, and maybe somebody can look that up for me, and wheezing and throat tightness. So if we start to see all of these symptoms, we're going to be looking for a rapid onset of shock. And that's what all of these symptoms really indicate to us, is that the blood pressure is going down. And really what happens is, due to the amount of histamine causing excessive vasodilation, the patient essentially drops their blood pressure, which leads to the inability to perfuse their organs. Okay. And once you begin to not perfuse your organs, this is where you start to all of a sudden run into challenges with maintenance of the systemic response to this allergic reaction. Okay. So there are a couple of different types of EpiPens that are available to us. Okay. We have the EpiPen normal, which is a zero point 0.3 milligram dose. Okay. Anybody greater than 66 pounds will get this one. It is yellow. And there is Epi. Uh, well, okay. That's what I kind of thought you were going to tell me. I guess I need to do a little better review of some things, before I post them out there. But like I said, I did it right before class. So, yeah, I've never heard that word before. So I don't know what that is. So EpiPen Junior here is for our people 33 to 66 pounds, has half the dose. It's going to be green. Now, what do I teach my patients? Okay. So you're going to take this thing, you are going to grasp it with your fist, orange tip down, and make sure that you're pulling this blue piece upwards. Okay. So that's kind of like a safety mechanism, it's a lock. Okay. We're then going to take that and we are going to push it on the outer thigh side of the thigh and hold in place for about 3 seconds. Okay. So just as some notes for you guys, if patients are using their EpiPen, this can go through clothing. It is designed to do that, so you don't have to get your patient undressed. They don't have to undress. This is just something where you grab the pen and you jam it in their leg. There's no process of, cleaning the skin or any of that that goes on. We have other priorities. If this patient were to get an infection later down the line, a cellulitis or something like that, then we are going to at least you got the med, Haley. um, um, the once you inject this, the patient should start to come around relatively quickly. Once it's injected, we're going to go ahead, massage that site, and call 911. Haley, how did you actually stab your thumb with that? That seems like a pretty tough thing to do.
I don't know. I was like 7 years old. It was a
We're-
bad situation. I don't think anyone had told me how to properly self-administer one, or I'm sure the
Sure.
doctor did at some point, and I'm a child. I don't know.
Sure, sure. Yeah. I mean, that makes sense. And that's why this is such an important concept to educate people about, is just how do we inject these safely and appropriately. As a 7-year-old, that needle had to really hurt in in your thumb. It's not, it doesn't come out very slow. So you'll hear like an audible click when it hits into your body. And you just kind of go from there. And again, once you do that, patients should start improving. That does not mean we stop monitoring them. In fact, we want to monitor them even more closely to ensure that nothing kind of goes sideways in that time that we're waiting for 911 to arrive for us. Um, so an important thing, know how to deliver these. There are test questions on how to utilize this EpiPen. It's not complex. Okay, so three-step saving solution here. So just make sure that that you're kind of taking a peek at that. All right. So let's talk about some of the other symptoms that we're going to see. Okay, so one of our more common symptoms, and usually this is a good thing to see because it usually gives us an indication that there is some sort of allergy that's occurring, but we're not at that life-threatening stage yet. Now, urticaria is just known as hives, okay? And they are these small raised elevations. They are associated with itching, and they can come and go in minutes to hours. Okay. This is not an emergency like anaphylaxis. This is simply something where we're going to say, let's give you some antihistamines for a little bit of time, and then we are going to see if that works. If it does not work, we're going to have to figure out a new solution, whether that's going to be the use of steroids, whatever it might be, if this advances into more of a chronic form of urticaria. Okay, so with these patients, we've probably all had hives before. Um, it does actually, Shelley. So stress hives mean your body is allergic to stress. Absolutely. So in fact, a good solution, just give yourself some epi and you'll feel a lot better. I mean, just for a little bit of period of time at least. So so they are not related. But with these hives, typically we want to identify the source, right? I mean, I think that's what this all comes down to when we talk about allergens, when we talk about these processes, is what's that source? And probably the more common sources that I think about are going to be things like that, the new shampoo that you're using, or that new body soap, or a lotion, or did you change soaps to wash your clothes, or that's usually what comes to mind when I start to think of this, but it can certainly be from eating things as well. It can certainly be from bug bites. It can be from a number of different things. But usually, first step in that process is identifying if anything has changed. I think somebody called that out earlier, so that we can best help that patient. So again, typically treated with antihistamines. Now, one of our major areas that we do get concerned about is our food allergies. Okay. And our food allergies, 5% of adults have food allergies. Typically, this is genetic related and can occur with any sort of food. And we range in symptomatology from simple urticaria all the way to anaphylaxis. So if patients do have some form of food allergen that can lead to anaphylaxis, typically that individual has an EpiPen by their side. Okay. Now, this there are some major food allergens that are out there. Okay, sesame milk, eggs, fish, crustaceans, tree nuts, peanuts, wheat, soybeans, and our newest member of this category, sesame. Okay, so with these food allergens, okay, um, this is why like food labels always list what is in there, and many things have to say this was created in a facility that also produces X, Y, or Z. So, like if you look at like a wrapper of something, it'll usually say that on there, to help prevent our patients from being exposed to some of these allergens. But you never know. I mean, the craziest things can happen. For here's a good example. Okay, and I know I've told you guys this before, but I swear all of the things I tell you are true. But my dad has severe allergies to like everything. Sometimes I think the man might be allergic to oxygen. Okay, but he is severely allergic to fish. Okay. To the point where, like, growing up, so in Wisconsin, one of our like cultural things is that on Fridays we go out and we have a fish fry. Okay. So this is either some sort of baked or fried fish that we can eat, that we do eat as part of our kind of normal routine on Fridays. Okay. Well, what happened, this is all part of German heritage, Catholic heritage, so on and so forth. Okay, so growing up, my family never went anywhere on Friday nights because the smell of fish could trigger my dad's allergens. Okay, so it's, let's see, I'm trying to read Sydney's message here. My sister was 4 and ate pumpkin seeds and went in, and I don't see seeds on there, but it is true. Oh, yeah. Well, okay, yeah. I mean, tree nuts, peanuts, etc. You're right. You're right. Um, so, but the point I'm trying to make here is that because of my dad's allergy, we couldn't go out to eat on Fridays, and it wasn't because like you're not forced to eat fish, but even to go to McDonald's, like it's all fish that they're making that night. It was so easy to cross-contaminate, even if they tell you, "Oh, we wipe it off. Oh, we do this. Oh, we do that." My dad's allergy was so severe that like even that was enough to trigger his response. So something that you can see and you just don't know when those allergens are present. So we do have to be very cautious with the different allergens. You probably know of some of the things that we have out there. I know like a lot of schools have peanut limitations. I know like this is another one. You guys, for those of you with kids, maybe see this, but I used to like be kind of proud that I could make my kids like a tray of brownies or something like that to bring into their class and share them with their friends. All that stuff goes away. It's like, yeah, it's got to be prepackaged. It's got to come from the store, so on and so forth, so we can worry about allergens, things like that. So, um, you see it everywhere. Okay, so it's one of our more common things that we do have to be concerned about. So, um, let's see, Maria, my class, yeah, peanut free class. You see that a lot. Like they don't serve peanuts like in closed spaces like airplanes as much anymore. Usually it's like pretzels or something like that. You just see that the peanut one is pretty much the one that I see them attacking the most. And attacking is a strong word, but it's the one that gets probably talked about the most, particularly at that young age. And you guys have probably seen recently that there's a lot of things coming out about peanut allergies and exposure and all that stuff. And trying to sort through all those things, but there's some evidence right now that indicates that, hey, you know what? Your kids won't be allergic to peanuts if you expose them to peanuts earlier in their life. I don't know if we know a complete scientific mechanism on that yet, so that's why I don't want to, make that our gold standard, but there is some general idea that exposure equals protection, which is not something that I would consider to be radical. I mean, we do these things called vaccines, which is essentially exposure means protection. Okay. So just something to consider as you're thinking about these things. All right. Now, a very common one that we see in healthcare is going to be the latex allergy. Now, latex allergies typically are caused due to obviously the latex, but the latex gloves that you might see oftentimes come with a powder on them, and that's to prevent them from like sticking together. Well, those powders can aerosolize. Okay. Yes, this is true, Shelley. Bananas and latex can go together. Very good. Um, so latex, the powder inside of the gloves can aerosolize, which means that maybe you'd breathe it in, okay, which would make that worse, right? Now, in the world of healthcare, we use a fair amount of latex products. I think I read somewhere that in general, a hospital is going to have about 40,000 products that still contain latex in them. Um, we have worked really hard in healthcare to eliminate a lot of latex and move to more silicone-based products, but not everything is that way. So you do need to check it before you use it. Okay, just make sure that there's no latex allergy that's going to be there. Um, and and strawberries is the same. Okay, so Haley and Shelley, yeah. Strawberries is the one I've always heard. I'm not surprised by bananas at all, but definitely something that you come across. Okay, so now outside of the hospital, there's less constraints around the use of latex. Okay. Um, so in manufacturing facilities, police officers, automobile mechanics, anybody who might be wearing gloves could be potentially wearing latex gloves, which means that they are ultimately spreading that latex protein around to some of the equipment that they're handling or whatever it might be. Okay. So as nurses, our job is to think about how do we decrease our exposure to latex? Okay. Well, first thing that we want to consider here is wearing non-latex equipment, wearing non-latex gloves. Pretty simple solution, right? So that's the first piece of the puzzle. The second is don't put lotion on your hands before using latex gloves. Okay. So you see this a lot where people, especially like when it gets cold outside and hands start to crack and dry out because of all the use of hand sanitizers and hand washing and all that good stuff, hands start to crack open. So we start putting lotion on. Okay. Once we start to put that lotion on, what happens is the latex proteins actually absorb into that latex, which eventually absorbs into the skin, which, as you can imagine, probably causes some pretty significant consequences for our patients. So, again, we want to be very cautious with that latex, make sure that we don't expose individuals that are allergic to it. And honestly, if you can use a product that is non-latex, that's probably the preferred option for these patients. So, very common to happen in the operating room because latex products are all over the place inside of there, but something to watch for. Okay. All right, guys. So that's all our allergic stuff I want to talk about. Let's move into some of the disorders that we have. Okay. Let's see. I'm just reading some of the notes here. Viviana, food allergies related to latex allergy, avocado, banana, kiwi, strawberry, tomato, passion fruit, and plum. And Addison, your work doesn't have latex gloves for that reason. Where do you work, Addison? Surgical center?
No, I work with hospice.
Okay. And you don't have any latex equipment?
Well, just gloves. I don't know about anything else, but
The other common one that you do have to be cautious with, I think this is the one that's most important for us as nurses, is Foley catheters. Sometimes those can be latex. And I mean, I don't know about you guys, but I think that's the last spot that I want to have an allergic reaction. So that's the area that you do have to pay close attention to. But many of them are moving to a more silicone-based product. The problem is that silicone's more expensive than latex, so you know the drill. Okay, if it costs a penny more, we're not going to spend money on it. We're just going to hope nobody has a reaction. But Okay, that's my soapbox moment for today. All right. So let's move into those rheumatic disorders. Okay. So last semester, you guys learned about osteoarthritis. Okay. So remember, osteoarthritis is a use condition. It is something that occurs because I overuse a joint and basically cause trauma to that joint, which leads to that arthritic condition. Rheumatoid arthritis or rheumatic diseases come in a multitude of different forms. Okay. They all come with very specific characteristics, though. They all come with inflammation, autoimmunity, and degeneration and destruction of the joints. Okay. Now, primarily for these patients, it is going to affect the joints. However, it does ultimately impact muscles, bone, ligament, tendons, cartilage, and it will affect multiple different joints in the body. It can affect just a single joint. However, more commonly, it affects multiple joints at one time. You don't typically see somebody with rheumatoid arthritis just in their one finger. It's typically their whole hand. Now, as the disease progresses, some of them are actually going to have more organs that are involved. And I think that's one key thing that I want to get across to you guys with these different diseases of autoimmunity is that they are systemic diseases. So while there is an area that is primarily impacted, such as the joints, okay, many situations lead to these antibodies causing destruction to other organs in the body, which is what makes them a problem. Okay. Now, I'm not saying that joint issues aren't a problem, but joint issues compounded by kidney issues are more of a problem. Okay. So let's think about that rheumatoid arthritis patient. Now, rheumatoid arthritis is considered an autoimmune disease. Okay. And it affects 1 to 2% of the population, with our females having a higher proclivity for the development of rheumatoid arthritis. And I know I've mentioned this before, but I'm going to pick on females all semester. You guys, unfortunately, get all of the diseases because once you hit menopause, your body is like, I don't know what to do anymore. So it just starts causing problems for you. So this is not something of opinion that I'm making up. It is something that actually happens. So, um, so when when we talk about a lot of our diseases, I will bring that up. You are hardcore. You are hardcore. I totally agree. I totally agree. What begins to happen here is essentially the body begins to have this. What basically happens is the body begins to think that normal cells are abnormal. Okay, that's just the kind of like the easy way to think about autoimmune type disorders. Okay, basically, the body believes that, hey, that normal cell that's always been there, now because my immune system doesn't quite work as well because I'm older, I'm menopausal, whatever it might be, those symptoms kind of gel together and lead to that well, it's only like 2 years, Amelia, and I would assume that it's like a painful 2 years. But but anyhow, the I can't remember where I was going with this anymore. Blah. Thanks a lot. Um, let's just go back to the slide. Okay. So what begins to happen, oh, I was talking autoimmunity. So as the body begins to lack that recognition, it starts to break those cells down because it thinks they're abnormal. It's basically like having an immune attack on itself, saying, hey, my job is to protect you against abnormal cells. These cells don't look normal to me, so let's break them down. So I start to break down all of that tissue, and it leads to scar tissue. And for many of you, you've probably seen a patient who has rheumatoid arthritis, and you can see the 10-year progression of the joint disfiguring that occurs as these patients experience this disorder. In 1992, you can already begin to see the early stages of that rheumatoid arthritis in the joints. You can see the enlarged knuckle here. On a couple of joints, you can even start to see some of this some of this start to the joints starting to pull away just a little bit, and then 10 years later you can see that significant deformity. I always felt bad because it was always such a weird thing to me. It seemed like anytime I took care of patients with RA, um, it always seemed like they had like these amazing jobs that required them to use like their joints, like a few patients that I've taken care of, they were like, yeah, I was a baker my whole life. And I'm like, well, that sucks. You can't do anything with those twisted up hands like that. I mean, how are you going to knead the dough and stuff like that? And we had a long conversation about that, and that was really hard for her. I took care of another guy. He had RA and he had Parkinson's disease. He worked on small engines. Like, how in the world are you going to put a small engine together if you're shaking and your knuckles don't work? So, sounds like a couple of you have some experience with this. Caitlin, I kind of think you're picking on your husband a little bit there, but we'll allow it. And then Shelly, grandma, has RA and severe osteoporosis. So not only was she all twisted, she'd break her bones while walking or sitting down. Yeah, that's a really big challenge there with both of those disorders. So typically, this is going to begin in the small joints of the hands and the feet. It's typically going to be bilateral and symmetric. So you're going to see it in all joints, again, differentiating it from osteoarthritis, where it is typically only the joint that is uh, being overused. Okay. So let's talk about the clinical side of this. All right. So what am I going to see? Again, I'm walking into my patient's room. I like these visualization things. Okay. I'm walking into my patient's room. And as I walk into the room, I notice that these things are happening to them. I go up to them, I introduce myself. Hi, I'm Joe. I'm going to be your nurse today. And usually, my first step whenever I take care of a patient is to reach out and shake somebody's hand. Okay. The reason I would do that is it's an amazing assessment. Okay. You may not think of it that way, but this is what it does for me. It's a neurological assessment because they follow my command. Okay. They reach out, they shake my hand. I can test their strength. I can feel whether that extremity is warm or cool. And and then I can also from that, I can assess part of their cardiovascular status, etc. So I love the handshake. Great tool. It's really helpful in assessing a patient. And during this time, I can look for things like inflammation, tenderness, stiffness of the joints. So asking the questions, how's your pain today? How much stiffness do you have today? If I asked you to get up, do you think you could? You know, those are things that we want to be evaluating every time we're seeing these patients. Now, most of them have more pain in the morning. Okay. Now, a key differentiator as well between rheumatoid arthritis and osteoarthritis is how long that pain lasts. Osteoarthritis, if you recall, when you get up and you start moving around, most patients will better. Okay. Patients with RA, they never really feel better. They kind of are always in this state of discomfort, which is why pain management is something that we're going to discuss here in a bit. Okay. We're going to look for joint deformities, as you saw in that image, and looking at that range of motion, particularly starting to think about how does this impact their ADLs? Okay. Are you going to be able to button your shirt if your hands look like this? Not very easily. Okay. So, and I'll tell you, it's kind of a weird thing because I think that when I say that, like, how easy is it going to be to button your shirt when your hands look like this? And I think all of you would say, well, the solution is don't use buttons, right? Okay. Well, I don't know if any of you have ever taken care of like 95-year-old ladies. Okay. They are stuck in their ways. Same with the men, except you just see this less with men. Okay. But they are stuck in their ways. And if they want to wear a button down blouse for the day, that's what they'll tell you. I want to wear a blouse. Okay. You're putting it on. All right. So you kind of have these like odd things that you got to start thinking, how is this person going to cook themselves some eggs in the morning? Okay. Probably not very easily, and I can't remember who brought it up here. Shelly, I don't know. Did you, and feel free to not comment here, um, but Caitlin, that's great. But did your grandma have issues with some of her ADLs at any point where you guys had to make some modifications?
Yeah, she did. She got to where like she couldn't open jars, couldn't, like you said, button her shirts. She couldn't, there were like a lot of things that she couldn't do. She loved to paint and draw. That became really hard.
Yeah. Yeah. So what kind of modifications did you guys come up with?
They have like jar openers that are like they have a handle that you kind of slide on the top. So she would use those sorts
Yeah.
of things instead.
Yeah.
Um, I'm trying to remember. It's been a long time,
Yeah.
but mostly
No, that's
just
okay.
having someone around to help her. My aunt eventually moved in with her, so.
Yeah. Yeah. It can be incredibly debilitating for these people. So, no, another thing that, obviously we have the joint issues, et cetera, but remember, this is a systemic problem that the patient is having. And one of the things that I think that we sometimes miss out on here is the amount of fatigue that occurs for these patients. Rheumatoid arthritis, because it is an autoimmune disease, is something that is always impacting the body. So it's basically like your immune system is always working. So think about this. Imagine if you had a cold for 365 days, okay, a full year, you're sick. How fatigued are you? How tired are you? That's because your immune system is working extra, which means your metabolic demands are higher. As I'm using more energy, I'm producing more heat, increasing my temperature. Now, it's typically low grade fevers, right? It's not going to be your 103 fever. It's just going to be something that exists and something that we have to be aware of. The joints are also going to become very spongy for these patients. And those systemic manifestations, such as the development of dry skin, dry mucous membranes, increased risk of things like cardiovascular disease due to the immune process that's occurring. There's just a number of different things that we begin to see clinically from a systemic standpoint. Okay. Typically, I wouldn't say that COPD is something we're going to see from this, Shelley. Um, more, I mean, you can certainly have some respiratory impacts, but I don't think I would call it COPD. Okay. It would be more of like an acute inflammatory response type of thing that would be more consistent with an RA as opposed to COPD. So was your grandma a smoker, Shelley?
She had been like years and years and years prior, but she had quit in like her 30s.
Hmm, hmm.
So
Any
that's why I
exposure,
was
like exposure to like secondhand smoke and things like that, or?
no. That's why I
Hmm,
was curious because it was like it was just sort of like stunned everyone. So I was just, and it was again years ago. It could be that
yeah,
it was not COPD and was something more systemic, but they just didn't.
sure. Sure. Makes sense. Yeah, I've never heard those two really greatly associated together as far as a causative factor. Certainly people have both at the same time, but I've never heard of them kind of being intertwined like that. But you never, I mean, I certainly don't know everything, that's for sure. So, all right, just a few more things I want to call out to you guys. Okay, on assessment. We are looking for a variety of different kind of visual symptoms that you might see on your patients. Okay. So a lot of patients, especially at their later stages, are going to develop these deformity in the hands. I always say that at this stage, this is when the hand is twisted up like a pretzel. Okay, so you can see the thumb deformities, you can see the deviation of the metacarpal areas, and the deformity in the fingers. Okay, patients can also develop rheumatoid nodules. These are basically just pockets of scar type tissue, almost like a cyst that develops. They can develop hammer toe and the hallux valgus, where the toe actually starts to kind of curve underneath the other toes. And this is kind of what that all looks like. You can see the destruction of the cartilage, which is leading to that deformity. So basically, I'm breaking down the supportive tissue that holds that in place, causing that deformity to happen. Okay. So for our patients here, we're going to have these nodules that you see in this situation. These are just some of the lumps that you will see. Oftentimes, this occurs in patients that have higher rheumatoid factors in their body. They are non-tender, they are movable, and they are often associated with progressive and destructive disease. Now, they can be removed or potentially let's see. Can someone have all the toe symptoms without RA? Probably. I don't know the answer to that one. Are you suggesting that you're in the market to be a foot model here, Victoria?
So, so listen, my mom and my grandma have all of those things on their toes. They've got like the bunions, the hammerhead, the one where like the one toe crosses underneath the other. And every time I go to get a pedicure, I'm like, so is this how to not have my feet look like that?
You cut out there a little bit, but I think I got the point there that's something that you maybe are a little embarrassed when you sit down at the pedicure station
No,
with mom and grandma.
mom and grandma. So yeah, I'm like, but they arthritis. So I didn't know. I guess it just happens without RA as well.
I mean, if they don't have RA and that's what their feet look, then yeah, but I don't know for sure what the interconnection there could be. So
Yeah,
Billy's making fun of you here.
he likes to do
So
that.
all right, guys. So we can also inject these with cortisone. Now, to diagnose this, all right, what do we want to focus on? All right. So every disorder of autoimmunity, we are going to utilize two specific tests. Okay. They are called the ESR, or the erythrocyte sedimentation rate, and the C reactive protein. Now, the it could be. I will tell you that both of these tests are good tests to measure inflammation in the body. Okay. They are great for that. What they're not good for, they are not good to diagnose a specific disorder. These are all things that we use in combination to decide, okay, this is probably what's happening. Okay, you do not need to memorize the values of rheumatoid factors and the ESR and the CRP. You don't have to know those normal levels. Just know that these are associated with autoimmune disorders and are commonly used in conjunction with other tests that we use. Okay, so our primary test that we use here is our rheumatoid factor antibody. Okay, now this is something that we can draw. It's a blood draw. The higher it is, there is oftentimes an indication that the patient has some sort of autoimmune disease. It is not just specific to rheumatoid arthritis, which is what makes it difficult to diagnose some of these diseases. We have to be able to look at the total package of symptoms and lab values in order to make the diagnosis. Okay. So I see I'm out of time here, guys. So I'm going to stop sharing. Um, and like I said, I'll get you guys a recording, likely tomorrow. Hopefully by midday, I have that done and out to you guys. So I'll finish up this lecture. And then if you guys have any questions, please just reach out to me and we'll make sure you can get through it. So, all right, guys, you have a wonderful day. Have a happy Tuesday. And I will see you guys all next week. I'll hang out for a couple minutes if anyone has questions. Take care, everyone.
Thank
Thank you.
you.
You're welcome. Thanks.